Tantawy, lecturer and consultant of neurointervention, منصورة University. اتفضلي يا دكتورة إيمان.
First of all, I want to thank Dr. Farouk Hassan for the kind invitation. It's always my pleasure to present over here. Today I'm going to present a case of thrombectomy for a patient who had a stroke as a complication of another interventional procedure. So we have a 35 years old female patient with no past medical history, incidentally discovered left carotid siphon aneurysm. She was planned for treatment by flow diverter stenting, and she was prepared by dual antiplatelet, and the plan was to be treated with flow diverter of FRED. Here we are to the angiography, first AP of the left ICE showing the carotid siphon aneurysm, and here the 3D is showing the same lesion. After this, we went for the procedure. Nothing was wrong. Over here on the right side, the right image showing the microcath passing the aneurysm, distal to it, and then the left picture showing the deployment of the stent or the flow diverter FRED. The final angiography was done, revealed patency of the left ICA, post-procedural expert CT was very good. Everything was going good, and even for the vaso-CT after the procedure, the patient showed that the vaso-CT, the FRED, is very aligned very well to the wall of the artery of the ICA. Left ICA with complete patency of the left ICA. 3 hours later, unfortunately, the patient developed, presented with right side hemiparesis, dysarthria, aphasia, and she was tuberous. The NIH was 8. The patient was presented to MRI and MRA time of flight immediately, which present left carotid artery occlusion and some flare and diffusion with imaging affection. So the patient presented, or the patient developed thrombus, most probably inside the stent or the FRED that was already deployed, despite of the loading of the antiplatelet. 1 hour after symptom, the thrombectomy was proceeded. Arteriography, or the first control, showed complete occlusion of the left ICA. Over here, only preservation of the left ophthalmic artery. After this, the decision was made to proceed for thrombectomy. We used RO9F as long sheath and then balloon-guided caster, distal access caster of Sophia Plus, microcath of Phenom 27 and 014 thin wire. It was very difficult to casterize the stent and the microcath through the thrombus. As you can see over here, the microcatheter and the microwire were not able to cross inside the FRED itself. It wasn't able to cross inside the thrombus. And with many trials, we tried with the Sophia we tried to aspirate for about 30 minutes without any, it wasn't successful at any trial of them. And then the decision was made that we are gonna inject intra-arterial IV altiplase through the Phenom. So this picture shows over here the IV, over here, the intra-arterial, altiplase administration through the Phenom. And after that, the control showed like mild improvement, about 50% recanalization from the FRED, from the flow diverter. That, as you can see over here, some territories of the internal carotid artery become apparent after the ophthalmic origin. And then we decided to go for expert CT again to make sure that there's no hemorrhage, no hemorrhage transformation for the lesion that was already apparent in the flare. Decision was taken to continue with another IV infusion of tirofiban, bolus and maintenance after this, after the procedure. Within 30 minutes, the pulse started. There was reduction in the residual stent clot, and with full recanalization TK3, as we can see over here on the carotid artery, from the APE and the lateral point of view. So the patient was, this was the post-procedural expert CT, no hemorrhage transformation, and the stent in the VAS CT, okay, it's appearing aligned very well like the first time, but we have residual of clot inside the flow diverter. So after the procedure ended, the patient was maintained on tirofiban infusion for about 12 hours. Within a few hours, the patient regained the conscious level. The NIH stroke scale dropped to 0. With the recanalization, the patient became completely normal, and she was projected 24 hours after this to another diagnostic angiography to see that the left carotid artery is still patent with TK3, and she was resumed on the dual antiplatelet as well as it was before planned. But we went for platelet reactivity test in order to just detect what happened, because the patient was already loaded with antiplatelet with aspirin and ticagrelol, and then the test revealed that there was a ticagrelol resistance, so it was shifted to prasugrel 5 milligrams twice daily combined with aspirin instead of the ticagrelol. And this was, the follow-up was CT 24 hours. We can see after the 12 hours maintenance of the tirofiban that the Fred diverter was totally recanalized, and the residual thrombus already dissolved from AP and lateral views. So this was the patient which has ticagrelor resistant. It's not very common to have something like that, but it happens. So here's a study is comparing between different flow diverters. Some of them are more thrombogenic than the other ones. Fred is proved to be more thrombogenic than pipeline, for example. And then another study was comparing between if the patient is subjected to ticagrelor and even prasugrel from the very beginning. It's not always very predictive. Sometimes it can cause as well, or the patient can go as well for intrastental thrombi, even if it was loaded. So it's not uncommon with the PY12 inhibitors that the patient will be completely covered or completely free from intra-stenting thrombi. And so the best thing over here that the patient, the study over here is speaking about, the patients can be monitored by doing the platelet function monitoring tests before even loading the patient, in order to see if any patient of them have ticagrelor resistance. So it's not going to work. It's better from the very beginning to shift to another type of antiplatelet in order to decrease the risk of intracranial intrastenting clot. And in the study, for sure, the group that was gone with the investigation is better, so much better than the control group that wasn't subjected to the investigation. And here is the guidelines for early management and thrombectomy that stated that we can, intraprocedural inside the thrombectomy, inject intra-arterial altiplase, or after this with IV tirofiban, in order to recanalize the artery whenever the aspiration or the stenting stent retriever techniques fail. And that's it for the case. Thank you.
Thanks, Dr. Eman, for this nice presentation, nice case, and nice review of literature regarding what was presented in the case. So I think Turuel has a question. Yes, please.
انيوريزم كده.
Excuse me.
اول صوره انيوريزم.
أول صورة.
اول صوره خالص. مش شايف حاجه. ما علينا. هي الدومينيك ريشيو يو كان دو ات مور سيمبلي ذان فلو ديفرتر. يعني انت الدومينيك ريشيو بتاع الانيوريزم نفسه واللوكيشن بتاعه حجمه ده مش جاينت انيوريزم، مش كومبلكس انيوريزم، مش ريجولار سيرفيس او في فيزيفورم انيوريزم تو بوشينج توورد فلو ديفرتر. You can do it simply from the start. Simple coiling will be enough for this aneurysm. If you do follow up and you find recanalization, you can find something to do like braided stent or flow diverter. But in this aneurysm, it's better. Especially we are in poor country, not there isn't. يعني flow diverter is a high costly procedure. Yes. That's my comment.
Yeah, this case was done back then with the team in Paris, so that's why they weren't concerned about the financial issues, and it wasn't ruptured, so there was no problem with the dual antiplatelet loading, and that's it.
Okay. Any more questions or comments? Maybe one question or comment, and then we go for the next speaker. Okay, thank you.
شكرا دكتور ايمان. Next speaker دكتور شريف محمد.